Hello, my name is Jose Mattos, and we're going to be talking about systemic medical conditions and inflammatory rhinitis. I have no disclosures. So today we're going to do an introduction on what rhinitis is, and then talk about different causes of inflammatory rhinitis. We'll start with allergic versus non-allergic. We'll cover immunologic and granulomatous causes for rhinitis, hormonal and endocrinology causes, pulmonary disorders, inflammatory rhinitis, and then we'll wrap up with some conclusions and key points. So chronic rhinitis, characterized by nasal obstruction and clear rhinorrhea, is common, with an estimated prevalence of 30% worldwide. And rhinitis can be the presenting symptom of systemic medical conditions or inflammatory disorders. And so we need to consider these disorders in our differential diagnosis. So let's start with allergic versus non-allergic rhinitis. So non-allergic rhinitis is more common in elderly patients and young children. And it's characterized, again, by nasal obstruction and bilateral clear rhinorrhea, in the absence of skin prick testing or serum testing showing atopy. Furthermore, non-allergic rhinitis patients lack the classic allergic symptoms of sneezing, itching, watery eyes, etc. And on physical exam, patients with non-allergic rhinitis lack that pale, boggy mucosa that is typical of patients with allergic rhinitis. Now, whenever we have someone with symptoms of nasal obstruction and clear rhinorrhea, there are certain conditions we must rule out. If someone has unilateral clear rhinorrhea, then we have to rule out something like a cerebrospinal fluid leak or CSF leak, especially if there's a history of trauma or that they have the demographic characteristics making them at higher risk for idiopathic intracranial hypertension. Anyone that has unilateral nasal obstruction should be considered at least as possibly having sinonasal neoplasm. And in children, we can't forget that foreign bodies can be a cause of similar symptoms. Now, these pictures show physical exam findings that might help you characterize allergic rhinitis. You can see in figure 1 that there's pale, boggy mucosa with clear rhinorrhea. And then figure 2 shows the transverse nasal crease or the allergic salute, and these are classic findings in patients with allergic rhinitis. Now, there are many different causes of non-allergic rhinitis, and we're going to cover many of them today. This table is here as a reference for you, so you can see the many different types of diseases that can have associated rhinitis. Let's start with immunologic or granulomatous diseases. First, we'll start with granulomatosis with polyangiitis, or GPA, previously known as Wegener's disease. It is an immune-mediated disorder of unknown etiology that leads to necrotizing vasculitis with granulomatous inflammation of small and medium-sized vessels. It's relatively rare, and it occurs mostly in Caucasians, but it can occur across multiple age groups and races. Classic otolaryngologic manifestations are recurrent sinusitis, otitis, and rhinitis is almost always present. Sometimes these patients can also have epiphora from obstruction of the tear duct outflow in the nasal cavity. Now, the physical exam findings of GPA are many, particularly in the sinonasal cavity, but the classic one is saddle nose deformity. And this is due to loss of this cartilaginous septum giving structure to the nasal dorsum, due to large nasal septal perforations as a consequence of vasculitis and vessel necrosis. Very frequently, these patients will have nasal crusting, which can be significant. And there are other otolaryngologic manifestations of GPA as well, like subglottic stenosis. Endoscopically, the nose of someone with GPA might look something like this. In figure 4, you can see significant amount of scarring and crusting, dry ulcerated mucosa. And in figure 5, you can see the erosive nature of GPA leading to a nasoseptal perforation, erosion of the turbinates, and also perforation in the palate, leading to what's known as the common cavity in GPA. It can be a very destructive disease in the nasal cavity. The diagnosis is both clinical, but also there are associated lab findings that we use. There are rheumatologic criteria for these patients, but also C-ANCA is a highly sensitive and specific test for this disease, although there are localized forms of GPA, meaning that they may not have systemic manifestations, and these patients frequently will have a negative serology. Imaging can be helpful. It shows thickening of the nasal cavity mucosa, maxillary sinuses with bony erosion, but these findings are non-specific. A biopsy of the tissue can be helpful if the diagnosis is in question. The key here is that biopsy must be a deep biopsy. A superficial mucosal biopsy will almost certainly miss the diagnosis. Untreated, GPA can be very serious and patients can succumb to their disease. The mainstay of treatment is local and systemic immunosuppression. And in terms of managing sinonasal symptoms, things like saline irrigations to reduce crusting and thick mucoid drainage with added antibiotics or topical steroids can be very, very helpful. Now, the surgical management of sinusitis or rhinitis in these patients really should be an option of last resort. Frequently, surgical intervention can lead to worsened scarring or worsened inflammation in the sinonasal cavities. And so really the management here is preferred to be done with topical treatments and systemic immunosuppression. Now, eosinophilic granulomatosis with polyangiitis, or EGPA, formerly known as Churg-Strauss disease, is a necrotizing eosinophilic vasculitis. It also is a relatively rare condition, and it has multiple stages. So the prodromal phase starts with asthma, atopy, and other allergic symptoms. The eosinophilic phase shows a preponderance of peripheral eosinophils, pulmonary disease, and/or gastroenteritis, and then the vasculitic phase leads to systemic vascular and extravascular granulomatosis. Very commonly, these patients will have nasal symptoms like rhinitis and sinusitis, and frequently you will see nasal polyposis in these patients. This figure shows a variety of different findings associated with EGPA, including mucosal edema, nasal polyps, scarring, crusting, and eosinophils seen in the soft tissue. This is a clinical diagnosis, and there are also rheumatologic criteria for this disease. You can also obtain blood work like p-ANCA or MTMPO. But again, sometimes or frequently, this blood work will be negative. And so clinical criteria are often relied upon to make this diagnosis. These patients frequently will have significant pulmonary disease, and a bronchoalveolar lavage can show eosinophilia. And again, a biopsy of the tissue can be helpful but not required, and must be a deep biopsy. Otherwise, diagnosis will be missed. And even with a deep biopsy, often these are non-diagnostic. Immunosuppression, usually with corticosteroids and EGPA, it's a mainstay of treatment. If that fails, you can escalate their therapy to other immunosuppressants. More recently, the development of mepolizumab, which is an IL-5 monoclonal antibody, which has been approved for EGPA, has really improved the treatment options for these patients and can be a helpful adjunct to help spare corticosteroids or immune suppression. And again, like in GPA, sinus surgery or nasal surgery is reserved for very severe cases, refractory to medical management, and really is a intervention of last resort. Sarcoidosis can also present with nasal manifestations. This is a immune-mediated disorder of forming non-caseating granulomas. That is the pathognomonic finding of sarcoidosis. It is more common in females and in Black and Hispanic patients, but can affect all races and age groups. The lungs are affected most of the time, and frequently there'll be sinonasal involvement in this disease as well, leading to chronic crusting, chronic rhinitis, obstruction, anosmia, and epistaxis. In addition to nasal crusting, patients can have CRS and polyps. They can have changes of the skin, leading to strawberry skin nodules, hypertrophy of the nasal skin, and often they will also have other otolaryngtic manifestations like laryngeal involvement, usually supraglottic, and salivary gland involvement, which can lead to Hereford syndrome, leading to fever, parotitis, uveitis, and facial nerve palsy. Endoscopically, sarcoidosis is a very distinct appearance, showing these diffuse submucosal nodules along the septum and lateral nasal walls. And biopsy of these nodules can show the non-caseating granulomas that are so classic for this disease. The diagnosis is based on imaging, soft tissue, and clinical soft tissue biopsy, and clinical manifestations. Chest imaging will sometimes show perhilar lymphadenopathy. Again, biopsies can show the non-caseating granulomas, and sometimes serum ACE levels can be used to help the diagnosis. To treat this disease, again, systemic corticosteroids, immune suppression, and treating this disease topically with irrigations and topical corticosteroids as far as the nasal cavity is concerned is preferred. Again, nasal surgery or endoscopic surgery is a last resort for these patients. That's true of most of these systemic inflammatory conditions. Surgical intervention really should be used very sparingly and judiciously. There are other granulomatous and immunologic conditions like lupus, Sjorgen's, relapsing polychondritis, tuberculosis, midline granuloma, and amyloidosis, which can also present with nasal manifestations, but these are less likely. Okay, let's move on to hormonal and endocrinology type causes of rhinitis. Pregnancy-induced rhinitis is something that you may very well see in your clinical practice. Estrogen is thought to increase glandular activity and increase mucopolysaccharide production and decrease mucociliary clearance, and also lead to increase in blood volume, leading to nasal congestion. It typically occurs in the later trimesters of pregnancy, and up to 30% of pregnant women can be affected by pregnancy-induced rhinitis. Nasal obstruction or congestion is the most common symptom, and smoking is a known risk factor for this condition. To make this diagnosis, the condition must not be present before pregnancy and should resolve within 2 weeks of delivery. It's prudent to rule out other causes of rhinitis that can be worsened by pregnancy. As far as treatment is concerned, if it is truly pregnancy-induced rhinitis, then it should improve or resolve after delivery of the baby. And in general, we want to minimize medication use for these patients, as none of these topical medications are known to be safe in pregnancy-induced rhinitis, although they are sometimes used. Hypothyroidism can lead to rhinitis or rhinitic type symptoms. It can lead to submucosal inflammation of the nasal tissue and decreased mucociliary clearance. And the presentation of hypothyroidism usually comes along with the other classic findings of hypothyroidism, which are fatigue, weight gain, lethargy, changes in voice, constipation. Sometimes patients have a goiter. So frequently you will see the other classic signs of hypothyroidism, but they also have associated rhinitis. And this shows you, just for your own information, the different manifestations of hypothyroidism and how they can affect our patients. The diagnosis is done usually with blood work showing elevated TSH levels, and the treatment is thyroid hormone replacement therapy, usually managed by endocrinologists or primary care doctors. Okay, let's move on to pulmonary disorders. Now, primary ciliary dyskinesia is a congenital defect in the structure and or function of the cilia. It's genetically heterogeneous with 33 known mutations, and it really is a spectrum of disease that can vary from isolated ciliary dyskinesia to cardiogenic syndrome with situs inversus, sinusitis, and bronchiectasis. This shows you the electron microscopy findings in primary ciliary dyskinesia. Is showing a complex defect in the inner dining arm and microtubule disorganization. And so it is this disorder in the cilia that leads to impaired function and mucociliary clearance. Frequently, this disease presents early in life with neonatal respiratory distress, asthma, bronchiectasis, persistent wet cough, chronic otitis. The most common symptoms of PCD are recurrent cough and rhinosinusitis, and there can also be significant middle ear involvement. Patients can also have nasal polyposis and situs inversus, and the other known causes of PCD, the other known sequelae of PCD, like infertility, blindness, and hydrocephalus. These images show that patients with primary ciliary dyskinesia can have a variety of findings on imaging, and they can have sinus hypoplasia, as well as mucostasis and central mucosal thickening. The classic finding in patients with PCD is really thick, inspissated mucus, and due to their inability to have appropriate mucociliary clearance. And again, these patients can sometimes have nasal polyposis or more significant centronasal manifestations of their disease. This is a clinical diagnosis, but frequently, or at least historically, the saccharin test has been used, where saccharin is placed in the nasal cavity, and the time it takes to transport it back into the oral cavity for the patient to taste the saccharin is measured. Biopsies of the tissue, if there are nasal brushings, can be done to look at the structure of the cilia, and also the testing genetic testing can be done to confirm the diagnosis. Usually these patients should be treated at specialized centers with a pulmonology team that is, and otolaryngology team that is used to treating these patients, and they can have a variety of sequelae from their disease. And topical irrigations and topical saline with steroids has been shown to be very effective in these patients. In these patients, surgical intervention can help if sinusitis is an issue, to help access of irrigations to help with the movement of this thick mucus, which is impaired due to their impaired mucociliary clearance. Cystic fibrosis similarly can have centronasal manifestations as well. This is a dysfunction of the CFTR gene that disrupts transmembrane electrolyte transport, leading to thickened secretions, and also in the sinus cavity can present with chronic sinusitis, nasal polyposis, thick nasal mucus, and chronic rhinitis. Typically, these patients present early in life with pneumonia, sinusitis, rhinitis, and bronchiectasis. Again, they can have sinonasal polyposis. Frequently, they'll have abnormal sinonasal imaging, but sometimes these patients can present later in life as well, depending on the severity of their mutation. The diagnosis is clinical, but then requires confirmation with sodium chloride testing or genetic testing. Similarly to patients with primary ciliary dyskinesia, these patients can have sinus hypoplasia and nasal manifestations like mucoceles or nasal polyposis, CRS, chronic rhinitis, as previously stated. Topical treatments are the preferred management for sinonasal disease. Sinus or nasal surgery can be used in these patients sparingly and judiciously. One must take into account their pulmonary status before considering surgical intervention. And there's a variety of new medications that have come on the market recently for cystic fibrosis that have really helped not only the pulmonary symptoms of these patients, but also their sinonasal symptoms. And these pictures show us what the appearance of the nose of someone with cystic fibrosis might be, with the classic inspissated thick secretions and nasal polyposis. Okay, let's move on to inflammatory rhinitis. So non-allergic rhinitis with nasal eosinophilia syndrome, or NARES, is a chronic eosinophilic nasal inflammation that is Th2 mediated. It has allergic rhinitis symptoms with negative allergy testing, so sneezing, watery rhinorrhea, and nasal pruritus. Anosmia, aspirin sensitivity can also be present. Sometimes it's thought to be a precursor to nasal polyposis. The diagnosis is made with clinically patients with clear secretions who also have a high preponderance of eosinophils in their secretions. Sometimes the nasal biopsies can show mast cells and mast cell degranulation. And the presence of eosinophils usually correlates to response to intranasal glucocorticoids. And the mainstay of treatment here is topical steroids and oral antihistamines. Now, atrophic rhinitis is something that is endemic to South Asia, Africa, Eastern Europe, and the Mediterranean. It is more common in females. And the etiologies are proposed to include bacterial, nutritional, and hormonal causes, although the exact cause of atrophic rhinitis is unclear. However, the most common organisms are Klebsiella usini, Staphylococcus aureus, Proteus mirabilis, and Escherichia coli. And chronic inflammation with lymphocytes and plasma cell accumulation is classic in these patients. Sometimes one can have secondary atrophic rhinitis, and that's due to trauma or nasal surgery, radiation, or recurrent infections. So this is an endoscopic view of the nasal cavity of a patient with atrophic rhinitis. You can see pale mucosa with thick crusts and purulent thick drainage. It's common in girls with the onset to be around puberty and symptoms worsening with menstruation. These patients can have halitosis or bad breath, anosmia, crusting, epistaxis, facial pain and pressure, and they'll have an enlarging of the nasal space due to erosion of the nasal structures, but they'll have paradoxical nasal obstruction. They will frequently have nasal septal perforations and saddle nose deformities as well, due to loss of structure of the normal nasal support mechanisms. Now, to make this diagnosis, you want to rule out other autoimmune and granulomatous causes. You must take a careful history, as always, physical exam, consider nasal biopsies and cultures, and imaging. And again, the treatments here are similar to other such conditions with nasal irrigations, humidifications, possibly antibiotics that can be systemic or topical. Decongestants and antihistamines are not indicated in these patients, and there's been some studies of plasma-rich platelet injections for these patients, but really the mainstay is really thorough topical nasal regimens. This is an example showing the injection of platelet-rich plasma into the nasal cavities. which is a treatment option for these patients if topical therapies fail. There are other inflammatory causes like basophilic nasal disease, nasal polyps, of course, immunologic nasal disease, which is non-IgE mediated. So to conclude, you should consider non-allergic causes of rhinitis in patients who have atypical presentations. And rhinitis can be the presenting symptom of rare but serious systemic diseases. And distinguishing the different causes of non-allergic rhinitis can help guide our treatment modalities. So the key points to take home here are the following. There are many autoimmune diseases that can cause rhinitis, including GPA, EGPA or Churg-Strauss, sarcoidosis, lupus, relapsing polychondritis, and Sjogren's disease, amongst many others. Hormonal changes can also cause rhinitis, particularly amongst pregnant women, and can be a symptom of hypothyroidism in non-pregnant populations. Rare congenital pulmonary diseases like primary ciliary dyskinesia and cystic fibrosis can also present as chronic rhinitis in young patients. And NARES should be suspected in patients with typical allergic rhinitis symptoms, but without signs of atopy. There are many great readings on this subject in our literature and our textbooks, and here are some that might supplement your readings and study of this subject. Here are our sources, and thank you very much for listening to our presentation today.